numbers. I know of no RCAs done on any of those deaths. So how are you, as a CCG, as a performance manager and a safety manager, addressing that situation? Because I'm rather alarmed that the situation regarding nosocomial COVID seems to be far too often in certain settings, that because the incidence of COVID is high in the community, there's not much we can do about it apart from the things that we're doing now. Thank you.
Thank you. I'll take that question. So I'll take it into two parts, if that's okay, Ian. So regarding RCAs, so if there is an outbreak, an RCA is completed and a root cause analysis to find out exactly what happened with the patients in regards to how the outbreak started and how wide that is and all of the implications of that and learning. Also, if there's deaths in UH&M or any provider, they go to a mortality group. So those deaths as well would go through the mortality group as well. So you'd have a two-pronged approach. You'd have the RCA in immediately to see if there's any immediate risks that need to be identified, that they need to improve their IPC. And then you've got the mortality group. Is that your understanding, Ian, or is there something else that you feel?
Yeah, that is my understanding as well.
Yes,
what worries me is it seems to be semi-sidelined, and it's the point I was making right at the end. Now, you will remember the MRSA situation, where it was taken very, very seriously, but eventually, now it can't be tucked away. These people died in hospital because they acquired COVID in hospital. I'm not attaching blame, but I think it can't be just shrugged off as high incidence in the community.
Okay, Steve just sent me a message just to say there's a national directive as well to do nosocomial deaths. Any nosocomial deaths or related deaths have to have a mortality review. But also I do know UH&M are doing a look back as well. So they're doing that look back as well.
Mm-hmm.
So they really are looking at it, and they're taking this very, very seriously, the impact. And I've spoken to staff, the impact on staff when a member of the public or staff members get COVID, it's devastating to them all, and they really do take it absolutely seriously.
And they're reporting it to you, yes?
Yes. Oh, absolutely. We're involved in their outbreak meetings. Public health are involved in their outbreak meetings. Local authority have been involved in some of their outbreak meetings, because obviously then you have to have track and trace outside of the hospital for the staff. So there's a lot of people that are involved in all of this. It's very open and transparent, Ian.
Okay. The report on Monroe.
Yes, the actual RCAs that you're referring to, they're actually taking place today. Right. We had a meeting with them on, I think it was the 3rd of February, regarding their RCAs. They weren't to the standard that we would want. We gave them additional support to dig deeper into those RCAs. We're not expecting any more learning than we've already identified. And in regards to John Monroe as a whole as well, CQC have been at every meeting with us, RCA meetings, improvement meetings, outbreak meetings, and I'll be very, very disappointed if that report shows anything that we haven't already picked up, Ian.
So the full report will come to a CCG governing body meeting?
It will come to the Joint Quality Committee. If the governing body want a full report here, then a full report could come here.
Right, thank you for that. My second question, sorry about that, was a bit prolonged, Chairman. Right, my second question is mental health.
Yes.
Ian?
Yeah?
Can you make sure you're succinct, please?
I'm trying to be as succinct as possible.
Unlike some of my executive colleagues.
Yeah, the third question is quite succinct. It's very, the long COVID one's easy. You're going to hit the mental health investment standards in 2020-21. Obviously, that's welcome. Looking at your budget setting assumptions, Q1 and Q2, you've stipulated how you're going to set the mental health budget. Right, but the question is around CAMS. However, there's increasingly concerning data of very significant demand surge for CAMS children being subject to very extended waits to access CAMS. And at the acute end of CAMS, the HSJ recently reported no acute CAMS beds were available in England, and children were being parked in adult mental health wards. A, are you aware of this? B, if so, how with care partners will the now significant and growing unmet need for children requiring CAMS be fully addressed? Thank you.
Okay, some of the question I can't answer fully, Ian.
Yeah.
The parts I can answer is the last part in regards to, I'm presuming you mean the tier 4 beds?
Yeah.
Okay, that is a national problem. And that is being escalated and discussed of how to resolve that issue, because it is wider than just Staffordshire and Stoke-on-Trent.
I think it's
Right.
worth noting, Lynn. Sorry, Lynn. Ian, as far as I'm aware, the bed situation actually should be addressed to NHSE, because in fact they commissioned the beds, not us. Although we keep complaining about it, because obviously we end up with the problem about having children with mental health problems in normal paediatric beds, which is not good for anybody. In fact, it's because of that lack of commissioned beds by NHSE that's the problem. You've probably seen from the white paper, actually, there'll be an awful lot of stuff that will be coming back to either ICS or to groups of ICS, and I suspect this will be one of them. But the situation can't wait for that to be sorted anyway.
Okay.
Well,
there's a community aspect, Chair, of this as well. There are community CAMS services and all extended ways.
And Wahid, I think Wahid wants to come in on that.
Okay, thank you.
Thanks, Chair, and thanks, Ian, for your question. I think the two parts to the question. One, the CAMS tier 4 beds. You're absolutely right. There's a national issue that's been around for a while. What NHS England has done, and this is commissioned through NHS England. So what NHS England have done, they actually worked with the providers, and it's called New Models of Care, to provide additional capacity. And I can tell you that locally we have had additional capacity over the last year or two, and by and large, I think we haven't had major issues in our area. We still have children out of area, and we're trying to bring them back. But I think it's kind of it's a national issue. You're absolutely right. There's a shortage of beds. But there is work going on nationally around this, and NHS England are directly working with the providers, and we are party to those discussions. With regards to the community waiting times, you would be glad to know that 4 weeks waiting time now applies to CAMS, all new referrals. And both our providers are actually achieving that target. So CAMS initial assessments are happening very quickly. I think what you wanted to say was that there's some issue with autistic spectrum disorders, ASD assessments. Yeah, that's where there's some issue. And we know that there's waiting time. We're trying to address with our providers, and we will be, if needed, we will be providing additional resources. But that's an issue. We don't have any capacity anywhere. We try to outsource capacity from private providers as well. But that's a growing issue we are aware of. There is a waiting time, but we will try to address with our providers.
Thank you very much for that.
Yes.
Right, long COVID. I asked a question at the last meeting about long COVID, and I'm following up from Margie Woodhead's points. I recall there was about 190k had been allocated for long COVID. I think it was around that amount, and I asked if there was any more money forthcoming. It was expecting more money would be forthcoming, because 190k isn't going to address long COVID needs. Have you got any update on any monies being identified that will be forthcoming to address a long COVID problem? Because as Marcus mentioned, 10% plus probably people discharged from an acute hospital after having COVID will have long COVID.
So in terms of the question about the money bit,
yeah.
Cheryl, do you know the answer?
I don't actually, but I'll get the answer and come back to you separately, Ian. You still on the same email address?
Yeah.
think it's worth saying there is some extra money because we've got a meeting to sort it out, but I couldn't tell you what it is, Ian. So
It's
that's
the
no
detail.
help to you.
It's the detail. I'll get it to you, Ian.
Well, I know a horse running on Saturday. Thank you very much for your answers.
I don't think that's a reasonable use of public money somehow. I don't think it'll get past our auditors.
Thank you very much, Chairman.
Okay. Are there any further questions from the public? Given that I can't see hands properly.
Chair, I can't see any further hands up at all.
Thank you, Tracy. In which case, thank you all for attending. Thank you for the questions from Ian and John. Thank you for those who have joined. We've got a confidential session after this. We need that 15-minute break. I suggest you go and do it.